Good afternoon, everyone. Thank you very much for joining. Jennifer and I, we're really pleased to have this opportunity to present on the 59 evidence-based practices and treatment that we've identified for individuals in the criminal legal system. As Braden indicated, this webinar is sponsored by NCHATS, but we also want to acknowledge a study that Jennifer and I are leading called the I Am Justice Behavioral Health Study. Many of you may have participated in that study since we've been sending surveys out for almost the last 5 years. And we've had lots of good people giving us information, which we use in different ways, and we'll explain that later. Next slide. So this study is funded by the National Institute of Mental Health. It includes NIMH is funding NCHATS, and it's also funding the I Am Justice Behavioral Health Study. What we're going to represent here is all of the opinions of the research team and not of the funding agency. Jennifer, do you want to transfer so I can do my own, or you want to keep moving?
It doesn't matter to me. It's up to you.
Okay. All right. So we start out with basically, let's talk about what is evidence-based policies and practices or treatments. So an evidence-based policy, practice, or treatment basically means that there is sufficient research evidence that a positive effect can occur by using whatever it is that's being tested. And what's important here is the concept of sufficient research evidence, which generally means that we're talking about more than one study. Generally, we're trying to look at the body of literature, and it's debatable what's considered to be sufficient, but we tend to use in the criminology field around 10 studies. That's a pretty high bar, I should admit. There's also the concept of evidence influenced, and that means that there is some clinical guidance and some research that can substantiate a positive effect. And what's important about the evidence informed or evidence influenced is that it really tries to integrate some of the clinical guidance along with some of the research studies themselves. So we're using these two core concepts as a way of defining what these 59 practices are. Next slide. Okay, so I'm sure many of you have seen the sequential intercept, which outlines, where people are involved, can be involved in the criminal legal system. There are essentially, 6 intercepts. And there are different reaches that each one has in terms of the number of people that are involved. So for example, at the community level, which means pre-law enforcement and pre-arrest, you can have 911 calls where 240 million people make calls on average in a given year, or you can have police contacts which may or may not be arrests, and that's around 53 million. And what's important about this sequential intercept, which was developed by Policy Research Associates, is that it helps us visualize where in the process we can connect people with different types of care. It also gives us information about looking at things downstream, like in the prior intercepts, or looking at things upstream and what the implications are. Next slide. Okay, so we wanted to kind of outline a couple facts, and I'm sure most of you are well aware of these facts, but one fact is that most individuals that are arrested, basically arrested for misdemeanor offenses or minor charges. Typically, those are over about 9 million cases per year. They account for about 25% of the daily jail population. People tend to be in jail for up to 72 hours if they are in the pretrial phase. And, essentially, once someone is arrested, it kicks off the regular criminal legal system sort of issues. The cases have to have some court attention. Judges process these cases. Essentially, we found that the majority of people plea, and in doing so, therefore, they have a criminal record. And although it's become easier in prior years to start expunging records, these records can stay with people for life. Next slide. So, the question that becomes, particularly for people with behavioral health issues, is, should we address the behavioral health issues, or should we be addressing the associated criminal legal issues that bring people to the attention of the criminal justice system? And there hasn't been that much research on the question about harms that are done using the criminal legal system, but there is beginning to emerge in the last 5 years more information how the criminal justice system involvement increases further involvement, that recycling makes it harder for people to participate in being employed, makes it harder for people to basically be productive. And the sheer volume of arrests of people that process through the system, those 9 million people, means that the system is overloaded. It treats people with minor offenses, usually very similar to people with more serious offenses, which basically reduces fairness and justice. And it basically makes it more difficult for us to identify health needs, including behavioral health needs, of those people who come to the attention of the criminal legal system. So there are consequences, and in many ways, there are harms that can actually occur from an arrest. And those harms basically have to do with the fact that both from a system level, the system is overloaded. At an individual level, some of that individual attention to really ameliorate or address some of the issues becomes more difficult. Next slide. So there was a famous study that was done that basically looks at the question, why should we avoid the criminal legal system? And the study essentially showed the benefits to reducing justice involvement. They basically found that non-prosecution of arrestees for misdemeanor offense over in a 2-year period of time resulted in further reductions, over half reductions of prosecution for other criminal complaints compared to those people who are processed. It had a reduction in new misdemeanor charges and even had a minor reduction in new felony charges. So the accumulating evidence is that, being involved in the justice system can actually be harmful to an individual, and in terms of their prospects, in the terminology of criminal justice folks, it's kind of a criminogenic factor, is that you create more criminals by, inclusion in the criminal legal system. Next slide, please. So there's benefits, and that's why the sequential intercept starts at 0 and basically focuses on what can we do at the community level. It also is the the sequential intercept is helpful for us to look at where can we divert people from further penetration into the criminal justice system. Because we found in studies that the diversion of individuals charged for felony offenses can reduce their probability of future convictions, and it reduces their total convictions overall. And it has a collateral benefit of increasing quarterly employment rates. as well as improved earnings over a 10-year period of time. So there's some real benefits to those early intercepts. And, you know, the system, to a large extent, through some of the police, social worker, co-responder partnerships, is really trying to find ways of advancing the use of those early intercepts. Next slide. Okay, you know, and just some other key benefits are changes the life course of an individual, and it reduces the stigma attached to an individual having a, you know, a felony, you know, rap sheet. Next slide. So what Jennifer and I are going to do is we're now going to present the 59 different practices. We're going to first begin by looking at those that affect policies and practices in the criminal justice system, as well as in the behavioral health system that directly works with the criminal justice legal system. And then Jennifer is going to talk about some of the treatments that are evidence-based and evidence-informed. We have an article that is available, you know, you can get it off of the PubMed, and therefore, you know, it's accessible. But this article details the information provided in this particular webinar. And as Braden said, we will provide these slides. And if you have any questions, you can always contact Jennifer and I. Next slide. Okay, so here are the evidence-based practices that are either offered in the criminal justice or legal system or in the community. In our study, we essentially found that 27% to 42% of the counties offer at least each one of these approaches, and that counties that had Medicaid eligibility enhanced the number of approaches that are evidence-based, and also enhanced the number of approaches that had to do with substance use treatment. So how you read this slide is, it basically says 42% of the counties offer a mental health treatment required by the court. So it's not necessarily a problem-solving court. Slightly less offer a problem-solving court. And then 40.6% have some type of integrated mental health or substance use services. And then you can go down, but I'm not going to go through all of them due to time, and you could read this on your own. Next slide.
Can I add one thing quickly?
Sure.
It just to keep in mind, these results we were looking at, are these services available to people with any criminal justice or criminal legal involvement anywhere in the county? So these might be in the jail, they might be in probation or parole, they might just be in the county, but people who've interacted with police can use them, right? So these are, yeah, they're present anywhere in the county.
Thank you. All right, so what we're going to do now is we're actually going to dive into the 28 criminal justice and community-based practices that are offered in the counties, and look at the effectiveness of these particular practices, as well as looking at some of the characteristics. Now, because of time, we're not going to go into a lot of the detail, but you will have the slides by which you can actually go back to some of this information. So what you have at the top level is the sequential intercept model, and then down below, you basically have the list of different types of evidence-based practices that we're going to be addressing here. The ones in green are essentially the ones that there is more evidence support, so they fall in the evidence base, and the ones in blue are those that are evidence informed. Next slide. And then, you know, again, these are integrated services. Next slide. Okay, so diversion or deflection, there's a new terminology that has emerged over the last 5 years. Basically, you know, we have to acknowledge PTAC, run by Jack Charlier from TASC, National Task, which is basically differentiated between deflection, which are practices that basically remove people from any criminal justice or criminal legal involvement, versus diversion, which diversion usually occurs after an arrest. And essentially, there's some formal processing of the criminal legal system that actually occurs. But these replace the actions by the criminal legal system by giving people access to treatment services. So you can see in this chart here that we've identified the key components of effective diversion deflection programs, and then we've identified the findings. So what we know best is that deflection and diversion programs that provide clinical services, those programs are more likely to be effective, and they're more likely to increase access to clinical care so that people can initiate treatment and engage more in treatment. One study essentially found that where there was a reduction in overdoses and in property crimes, that particular study was not replicated. But there's a lot of potential benefits, as you can see by the findings: reduced involvement in the criminal legal system, increased employment, you know, better outcomes for minority members. And essentially, you know, this model provides a way of basically handling people with behavioral health issues, where you can avoid much interaction with the criminal legal system. Next slide. Mental health courts. So everyone's heard of problem-solving courts, which are specialized courts that attend to needs of individuals. These particular courts usually are, you know, about treatment, testing for drug use, and rewards and sanctions. They're usually involve a judge, and they're usually involved with a coordinator or personnel. There's, you know, the National All Rise now, instead of the National Association of Drug Court Professionals. All Rise basically has identified 10 key characteristics, and they include things like screen for mental health needs, provide mental health treatment, provide medications, and engage in medication management. The findings are positive here. There's a small to moderate impact for mental health courts on reducing recidivism, and there's more engagement in treatment when the services are part of the court process. So, you know, there's a lot of benefits that come, and as you saw, more counties are likely to offer these types of courts than some of the other evidence-based practices that we're going to look at. Next slide. Permanent supportive housing for individuals with mental health conditions or people who have housing stability issues. So, you know, one big question always is should the criminal legal system deal with social support or social stability issues like housing? And it's clear that when you can provide housing, the housing can address the health or behavioral health needs of the client. And the housing can actually be a factor to reduce homelessness, to reduce housing, to improve housing stability. It also has the benefit of decreasing ER visits and hospitalization. And when people are housed, they tend to have stronger client satisfaction. Key component here is that the housing should be offered without any real attention to making sure the person is clean or able to care for themselves. The housing should actually be able to be offered so that the person can begin to get some stability. And so the question that becomes is, should we be thinking about permanent supportive housing? And it seems to me that the evidence suggests that this is an important initiative. Next slide, please. Okay, integrated mental health and substance use disorder services and programs. There's been a long debate in the field because mental health services are usually offered by a different agency than substance use disorder services, and therefore people had to be duly enrolled in different programs. But the notion of providing integrated care, which makes sense because of the high number of people, high prevalence of people with co-occurring disorders, is that you could provide integrated care that addresses both substance use issues as well as mental health issues. The key components here are you have the same clinician, you have the same program, you basically can use some of the effective treatment practices that Jennifer is going to talk about. And you essentially, have the opportunity here to provide case management services for supports for housing, employment, and family issues. The findings right now are, and this is why it's in the evidence-informed bracket, is that there is some findings that show that these integrated programs reduce depression and anxiety. There are some other findings that basically find that there aren't outcomes yet in terms of treatment retention or substance use or overall functionality. But the general gist of the literature is that if we want to reduce the burden of people having to manage multiple programs, that this is a model that's worth considering. Next slide, please. Assertive community treatment or forensic community treatment. Assertive community treatment is a type of case management services. It's usually provided for people involved in the criminal legal system with the expectation that they'll be able to address both the social needs of the client as well as the needs related to their criminal behavior. The general findings are here that there is a modest reduction in homelessness. There's a small impact on psychiatric symptoms and severity. There's a small impact on treatment retention. There doesn't seem to be any real impact on criminal justice outcomes. There's a variety of treatment components that can be part of assertive community treatment. And so, you can see the list here, and we'd refer you to a document by SAMHSA that looks at the different types of service delivery models. Next slide. Supported employment, sort of like supportive housing. The notion is that you really help people get and acquire jobs and maintain jobs. You put people in employment positions that also gives them assistance to manage the stress on the job, but also to deal with some of the social skills needed to function in the workplace. Essentially, these are positive findings where you have higher rates of competitive employment, fewer days that it takes to get to the first job, so people are able to get employment easier, longer retention, and higher wages. It increases the level of employment and the length of time of employment. So, what's important here is that the supportive employment can deal with the employment, but it also can deal with some of the other services that people often need, such as housing support, some of those soft skills that are necessary to be successful in life overall. Next slide. All right, so I wanted to bring your attention to a recent article that was produced by a number of colleagues led by Aaron Hogue at Columbia University. And it talks about linkage facilitators. So I'm sure many of you are well aware that peer navigators are useful supplements to case management services, to the criminal justice legal system, to mental health services, because they provide some of the supports that often are not available in the busy, processing that occurs in the criminal legal system, as well as the overwhelmingness of the people in mental health and substance use treatment services. So what Hogue and colleagues have done is given us a typology of what types of linkage facilitators there are. And they basically identify that they range considerably from licensed clinicians to certified peers to other peers. Now, why I think this is important for you to pay attention is because you can assess your system on what kind of peer supports are actually available and whether or not your peer supports, are designed to really deal with connectivity. So you'll see the second to the last row is about linkage connectivity, which is about integrated connectivity, putting people actually in programs and services versus other types of less direct connectivity, such as a warm handoff or a passive referral. So I provide this a conceptual framework because increasingly programs are using peer navigators, and there's lots of choices that you have to make in terms of what you're really looking for the navigator to do, as well as what are the choices in terms of what kind of outcomes. Next slide. So co-responder models, which are usually the integration of police and some sort of social work teams to respond to calls for services or incidents that involve people with mental health issues. These co-responder models are increasingly using peer navigators after the initial incident to maintain contact with an individual and to be able to help with some of the follow-on care to reduce other instances of mental health crises. So there are a number of very positive benefits that can occur. There's behavioral health findings, which is giving people more access to care, providing more opportunities for follow-up, and decreasing hospitalization. There's also criminal justice findings that include decreased likelihood officers will use force or lethal force, better use of police officer time and reduction in citizen injuries, and improved police understanding of how to deal with these crises, and when an arrest is needed and when an arrest is not. So that's one aspect of the peer navigator linkage. Next slide. Another aspect is the mental health peer navigator system. And those typically are people with lived experience who are in recovery, or they've had some sort of mental health condition themselves, and they support individuals. What's advantageous here is these can be certified, and therefore, people can get employment by having this type of, in this type of position. It inspires hope that people can and do recovery because a client is working with someone who has walked that walk. And so that can be a very positive aspect for individuals. And it provides all sorts of ways of dealing with myths that occur about substance use and mental health issues. In the mental health field, peer navigators have been used more predominantly than in the criminal legal system. And there has been a literature that basically talks about improvement in self-esteem and confidence, a better sense of control and ability to make changes, improved empowerment. So you can see a lot of advantages here. And, from the criminal legal system, the studies are soon to come out that look at what are some of the advantages of using peer navigators. Next slide. All right, to go along with the peer navigator system is essentially crisis call-in centers. So these are centers that basically people can call in to request services or to address crisis statuses. This is like 998 hotlines that exist for suicide prevention. They are also like services that are basically allow people to call to get access to mental health services. They can be independent or they can actually be part of emergency response systems. So far, we're learning more about these sort of crisis centers through the 988 initiatives that have occurred over the last couple years. And most studies basically have focused on what happens at the end of the call. But if you think about the peer navigator and the co-responders, having these sort of crisis call centers is a good way in your community of being able to have a cadre of services that will allow for more access to treatment instead of reliance on the criminal justice legal system. Next slide. Critical time intervention or case management. So within the research literature, there is something called the critical time intervention initiatives, and these are basically activities that are mobilized at some point in a person's life, usually at some transition point. So these studies have basically been used with people who are veterans or people who have unstable housing, likely to be used for people at different transition points as people are leaving jail or they're leaving prison or they're leaving a psychiatric facility. And essentially the findings are that they tend to be associated with lower probability of arrest and a greater likelihood of engaging people in treatment services. So the notion here is that you provide the service at the point of transition. It's really designed to decrease some of the anxiety that occurs as people move from one setting to the next. And, it's basically allows for the ability to really individualize the care to that particular individual. Next slide. Within the therapeutic literature, there is this notion that a good working alliance between the therapist and the client is healthy. It increases the trust and the client fares much better. That same logic has been tested within the criminal legal system in a number of studies. And, we basically find that when a client feels comfortable, trust their criminal justice staff, they feel that they're being treated fairly, and that they feel that the criminal justice staff care about them, that you tend to have better findings overall. So this therapeutic alliance concept is applicable and very relevant to staff who work within the criminal legal system. It is part of the evidence-based supervision model, which is that you develop a good working relationship with clients overall. Next slide. So there's a lot of discussion about continuums of care. And one particular one is the coordination of people between jail and the community, particularly around providing continued care for medications, mental health services, substance use services. So the notion here is that, you know, what starts in jail continues into the community. And that can be done in various ways. It can be a light touch, like helping people set up appointments. So when they leave the community, the mental health appointments or medications are already readily available for them. Or it could be an actual linkage in which there is, you know, a transition, or the healthcare provider is actually involved with the person when they're in jail and then move into the community. You know, this has been a topic of conversation in the criminal legal system literature for about 25 years. And we're still struggle with trying to provide adequate transition, but we know there are a lot of benefits that come from this transition in terms of improving public safety, reducing psychiatric symptoms, reducing hospitalizations, relapse, suicide, and rearrest. And so, you know, one of the suggestions here are that people should actually really develop these coordination services. And there's a lot now that can be done with technology. We don't have time to go through this today, as new ways of thinking about some of this coordination of care. Next slide. Something that's also talked about quite a bit is the cross-training of staff for people who work in behavioral health settings and criminal legal system settings like jails. So there's a lot of benefits that come from cross-training. One of them is a focused awareness of what are mental health issues and what are the appropriate responses. Other benefits that actually can occur is, you know, the criminal legal system and the behavioral health system can develop better relationships between them that basically fosters more quality programming. So these cross trainings are very useful and, you know, provide a means by which people can share information about their organization or processes, but they also provide opportunities for new initiatives for the teams. Next slide. One area that is identified as an evidence-informed practice is family caregiver education and support. Now, this is an area that actually people struggle, jurisdictions typically struggle with trying to provide, but here you're working with the family or support system of the individual to help them learn how to deal with some of the issues that come from having a mental illness, that come from being involved in the criminal legal system, and help to prepare these support systems to be better resources and to be able to know what to expect. You know, we have long recognized how important support systems are for individuals. You know, we all need our support systems, to be honest. We're human beings. But here, what we really want to do is we really want to prepare the support systems to be able to work better with the individuals. So studies have essentially found that social support systems are very beneficial for the caretakers themselves. That reduces depression, it reduces some of the anxiety. It helps people to better understand how to handle situations. And there's benefits for the individual overall, because a stronger support system can really help someone be able to function better, and also to be able to manage their recovery better. So, as I said, this is a type of evidence-informed practice that is less likely to be offered, but there's a lot of advantages that can actually occur with providing this type of training and care. Next slide. Okay, so I'm going to conclude by basically suggesting that, all of these programs are individual programs, but the programs essentially need supporting policies in order to be effective. And those supporting policies go from, having standardized screening and instruments, better referral and linkage strategies, better treatment placement strategies. So those are functional operations that organizations can have, all the way to making sure that you have the ability to pay for these services. Now, actually, Medicaid coverage and the 1115 waivers on Medicaid, which are designed to really provide care when people start in jail or prison and continue into the community. All of those ensure that you have some of that funding available to be able to provide these quality of cares. Another important supporting policy, though, is to have performance measures that you can look at how your system is functioning. And we like to refer people to the Cascade of Care, which basically serves to essentially help look at how well is your system doing in screening people, in referring people to services that need services, in helping people get to the door, initiating services, and then helping people stay engaged in care. And so those policies or performance measures are something that are very valuable. And finally, we need services that have to deal with moving people as their recovery or their stabilization occurs, where you can step down the level of care or step up the level of care if someone is in distress or needs more services. So you have to think about your supporting policies. Next slide. So Jennifer, I think this is where I turn it over to you.
Yes, thank you so much. That was great, Faye. So I'll tell you about the evidence-based mental health treatments. I will try to be done by 2:15 so we can have some time for questions. Okay. And it was really interesting, I have to say, doing this project, because Faye's a criminologist, I'm a clinical psychologist. And so there are different levels of interventions, right? There are these system level interventions like diversion and deflection. And then I would call these evidence-based treatments, diagnosis-specific treatments that improve mental health. This is the slide that I'll go through. Each of these that I'll talk about was offered to people involved in criminal legal systems, either in the community or in custody, but in between 23 to 40% of counties. And I wanted to, and let me just go back, when we were looking through the literature to identify these practices and treatments that we're talking about, I was really looking at what is the evidence that they improve mental health, and many also improve criminal legal outcomes. But primarily we were looking at, do they improve mental health outcomes and substance use outcomes among people involved in criminal legal systems. So as a reminder, when we talk about that, we are talking about everything. We're talking about crisis lines, 911, law enforcement, pretrial jail detention, parole, probation, anywhere in the county. And as a matter of fact, as we're talking about this survey, we reached out in counties to the head of community mental health, head of substance use treatment for the county, jail administrator and probation administrator to see, you know, is this service offered to anyone with any criminal legal involvement anywhere in your county? And then actually, I'll say one other thing that's come up. It's really interesting. So while we were doing these countywide surveys, we actually pulled existing public data for all counties, I believe. And our colleague published a paper and found that in any given county, the violent crime rate in the county did not predict per capita jail population. So divided by the population of the county, violent crime didn't predict how many people were in jail. But the factors that did predict how many people were in jail had to do with the presence and accessibility of mental health and substance use services in the community. So, you know, things like affordability of substance use, you know, amount of publicly funded mental health treatment available. And so while there are, you know, mental health is not related to many of the reasons people end up in jail, there is this group of people, and it's this, I would say probably a significant minority of people who end up in the jails, and maybe even more than that, of people who are interacting with police who are doing that because their mental health and substance use is not well managed. And if it were better managed, they wouldn't be interacting with the system. Hence, you know, all these treatments I'm about to tell you about. Okay, so interventions to address suicidal thoughts or behaviors. I'm going to talk about this. So let me tell you a story. So you might wonder, you know, what does suicide have to do with the system? So one of the people that was in one of our projects, he was trying to rebuild his life. He something happened at work and he got laid off from his job. He began to get despondent for his future. He was worried about losing his relationship with his son over this. He went home, he started drinking. As he started drinking, he started to get more anxious, more worried, and think more hopeless. And he decided to try to end his life by crashing his car on the highway and making it look like an accident. So he did that, and in the process, he was pulled over for drunk driving and arrested and taken to jail. And the police didn't know they were dealing with someone in the middle of an active suicide attempt. And again, you know, people end up in jail for many reasons, but it's been interesting in doing the suicide work. Our work found that 1 in 5 US adults who die by suicide in the US each year have spent at least one night in jail in the past year. And a lot of the things that suicidal people do to try to die, like overdose, like reckless driving, potentially even setting fire to buildings that they're in, are also illegal. And we've seen many cases of people ending up in jail when their intent was suicide. The other thing I'll say is the gold standard definition of a suicide attempt is anything one does with non-zero intent to die. So this sort of old concept of like a suicide gesture, or they didn't really mean it, or they couldn't have died from that, we don't do that anymore. If the person did something and thought that they could die from it and had some intent to die from it, we take that seriously as a suicide attempt and they need care. Okay. So safety planning intervention for suicidal thoughts and behaviors. My colleague Lauren Weinstock and I did a study of 800 people leaving pretrial jail detention. And again, like I said, this is 1 in 5 suicide deaths of adults anywhere in the US are in this group, right? And found that the safety planning intervention reduced suicide attempts over that year, the number of suicide attempts. And this is an intervention. It doesn't try to solve all your deepest problems, but what it does is help people think about their own triggers for what makes them feel suicidal, and what are steps they can take to distract themselves, to think about something else. Who could they potentially call? What crisis services could they call? How do they make their environment safer so that things that they could use to kill themselves aren't just sitting around on the table. And this is a very effective in general for suicide prevention and is now shown to be effective for people involved in criminal justice and criminal legal systems. DBT for suicide prevention is also evidence-based. I don't think it's been tested specifically in criminal justice populations, but to the extent to which, like I said, a lot of those folks are actually in the community, and in any given time, this can help reduce suicide. And there's also CBT that's specifically for suicide prevention. CBT is kind of interesting because a lot of, so for example, if I talk to somebody who's not a mental health clinician and say, do you have CBT? They say yes, but CBT is actually specific to different things. So there's CBT for criminogenic thinking, which uses similar principles, but has nothing to do with CBT for suicide prevention or CBT for depression. So when you see CBT for a specific thing, it's for that specific thing. All right, so depression. So, a lot of folks in, going through criminal legal systems have major depression. Actually, let me just take one step back to talk about suicide. The reason I think, like I said, we've been doing this work on suicide prevention for people interacting with police and getting arrested and, after pretrial jail detention for a while now. And there's a lot of comorbidity between the criminal legal involvement and the suicide. And I think it's really interesting. Sometimes people think people are suicidal because they're arrested, which can be the case. But in the folks we followed, often sometimes they're arrested because they're suicidal, but more often it's just a marker of chaos in their lives. And as a result of that chaos, they are both suicidal and they end up getting arrested. And so again, that sort of speaks to this, how strengthening these services in the community can help people whose lives are in chaos manage the chaos in ways that don't land them in jail. All right, interpersonal psychotherapy for depression. Again, evidence-based in community, in custody. I actually did a study that was the first randomized trial of any treatment for depression among people who were incarcerated, and found that IPT was really effective because the things people worry about at night are things like, is my family okay? People who have died, that worrying about people around them. So we found it was effective at reducing depression, reducing hopelessness, and reducing PTSD, actually. Again, here's another treatment for depression. I know many of you, probably some of you are psychiatrists or physicians, many are not. But, a lot of, depending on the mental health condition, depression is one that is responsive to both talk therapy and medications. Many mental health conditions are. Some require medications. And so, if you're not somebody who loves to go down the list of what medications are in your formulary, talk to the person who is and make sure that you have those covered. Okay, so bipolar disorder and mania. These are symptoms of bipolar disorder and mania, and they have to last, whoops, let me go back. The symptoms have to last 7 days. And this is really, it's sometimes if you ask somebody, have you ever been unusually excitable, high or hyper? They'll say, oh yeah, I had a wild night or something. But this is somebody who for at least 7 days is abnormally upbeat, jumpy, or wired, edgy. You can see people often, like I will see people pacing at the bus station, looking very agitated, exaggerated sense of well-being and self-confidence. So, and increased risk-taking. So this is a disorder that's pretty biologically based and impacts people's judgment. So, for example, I had someone with bipolar disorder. He was an older man in his 60s or 70s in a wheelchair who got manic and decided he was going to fix his roof by himself. right? That's not a good idea, but a lot of things other people do when they're manic, pick fights, use substances, cause problems. And not surprisingly, of people with bipolar disorder who get arrested, about 3/4 were manic when they got arrested, because this is a disorder that can make you pretty disruptive. So again, if it's better managed in the community, then we won't have people getting arrested because they're not well treated. Mood stabilizers, people who are manic need medication, full stop. There are psychological things that can also help, but they just have to have medication. Education about bipolar disorder and mania for both people and their family members are really important, because one of the things that happen when you're manic is that at the first it feels great. You feel really confident. You are enjoying the world. Everything gets larger. There's a wonderful book called The Unquiet Mind by Kay Jamison. She was a psychiatrist who also had mania. And because you feel great at first until you don't, it's hard to convince folks to stay on their medications. But they need to stay on their medications because this is a relapsing disease that tends to get worse over time. So what education can do is help them and their families realize that just because you feel good today doesn't mean you don't need your medication. All right, so again, family education to understand how to deal with the person, help them take their medication. And you know, I have to say that I have respect for people who have this disorder. I've counseled people who were mental health clinicians and had a full understanding of bipolar disorder and themselves had bipolar disorder, were experiencing manic symptoms. And yet, when you're not manic, you just don't think you need your medication, even though they sort of should have known. Like it's very slippery that way. Okay, treatments for schizophrenia or psychosis. This includes hallucinations, so hearing, seeing, feeling, or tasting things that others don't, or hearing voices whispering or talking, or delusions, which are an unshakable belief in things that aren't true, like extreme paranoia, thinking the CIA is after you and all that sort of thing. So again, this is another one where the first line of treatment is medication. There are also talk therapies that can help with that. I will list them, but these folks really need medications. And actually, let me go back. This is one where, interestingly, of the people we surveyed in counties, only 30% or something said that medications for psychosis were available to people with criminal justice involvement in their counties. I hope that we just asked the wrong people, because that's a standard of care issue. They really need medications. So there are CBT and talk therapies that can help with psychosis, but what they mainly help with is, for some people, the medications treat everything and they can function, but a lot of people have functional challenges. And what the talk therapies can do is help you live with the symptoms that you have despite the best medication, and to help you function. Family education about schizophrenia, psychosis is important for the same reason that it is for bipolar disorder, is to reduce distress, help people understand how to deal with their loved one who is acting in a way that they don't understand, to be on their medication. I have a close friend who has a son with psychosis, and thought that the right way to help him get better was by explaining to him how all his delusions weren't logical, but that's actually unhelpful. It upsets people more. So, you know, there are just some things about how you deal with a loved one or a family member or a friend who's having hallucinations and delusions that can help both them and you, and help sustain access to care. All right, social skills training for schizophrenia or psychosis. Again, this is around helping the person function in society, to be able to potentially keep a job, or you know, to manage doing the daily things in life that involve other people. This is a class of medications, like I said, that should 100% be available. This would be, for me, the first line of treatment. Ditto, here's another class of newer medications that have fewer side effects. It's interesting because some of these, so all of these should be available. sometimes in custody, a couple of these aren't on the formulary, like Seroquel, for example, is not on some formularies because someone decided it could be maybe habit forming. I guess I'm not a psychiatrist, I don't know about that, but talk to your people about the formularies and what's available to the folks you're treating. All right, borderline personality disorder. A lot of folks who end up interacting with police or in criminal legal systems have personality disorders, which are these sort of long-standing over many years patterns of behavior. A lot of folks with borderline end up can have interactions with the criminal legal system. For example, I had a friend who got mad because her boyfriend was cheating on her, so she threw a flower pot down the stairs at him, which is assault, and she was arrested and spent a couple of nights in jail. But these are folks where you struggle with a sense of self, chronic feelings of emptiness, can have intense anger, problems controlling anger, and feel threatened pretty easily. DBT is effective for that. There again, medications can be quite effective, can help a lot, especially with some of the mood. In borderline personality, the mood changes really fast and you have these angry outbursts. Medications can help. Post-traumatic stress disorder. Many people who interact with police or crisis lines or jails have PTSD because you're, disproportionately getting people who've been exposed to violence, who perhaps been victims of violence or observed violence, and have flashbacks. Actually, it's really interesting. If I could, something I think that is under addressed in jails, and the jails, I understand why they can't do anything about it, but I know lots and lots of folks who've gone through custody who just absolutely cannot sleep because every time they close their eyes, they're having nightmares and flashbacks. And because the prison formularies, a lot of the things that can help with sleep are habit forming, they're not really available. There are good behavioral things you can do for sleep, but again, a lot of people don't know them. So PTSD. So again, these are effective talking therapies for PTSD. Prolonged exposure. If you need to do this with a trained clinician, but actually just going over it over and over and over again, oddly and kind of counterintuitively, will get rid of the flashbacks. Seeking safety. This is an intervention for people with both substance use and post-traumatic stress disorder, which go together often. As a matter of fact, people with mental health conditions are disproportionately likely to also have substance use conditions for a variety of reasons, but not the least of which is that they, with PTSD, they'll often drink or do something to try to help with the flashbacks. Again, medications, very effective. It's been, there's a history with 12-step and whatnot that there's this thought that you don't, take a substance to recover from a substance, but more and more lately, that what we're finding is, psychiatric medications and other medications are incredibly effective and important. And like I said, for some of these disorders, absolutely required. Again, another class of medications that can help with the flashbacks. Other anxiety disorders. I maybe won't go over these. But there are effective treatments for anxiety. So if you have someone washing their hands a lot, stressing out, again, unable to sleep, there are effective medications. Insomnia, like I talked about, there are very effective behavioral interventions. The jails where I know will sometimes give people cough syrup and they'll have handouts on sleep training, but actually some of this behavioral treatment for insomnia is pretty specialized and there aren't a lot of folks, clinicians who know how to do it well. So this is something I think that is probably, community, probably any mental health organization could use more expertise in this. Physical pain. And again, you wouldn't necessarily think of this, but you know, if you're working with people who are addicted to opioids, a lot of what, I mean, you get the withdrawals, right? But some of what happens in the first place is untreated pain. So I had a woman I worked with, she was actually a kindergarten teacher who was in an accident, got prescribed opioids for her back pain, became addicted, and then heroin was cheaper than the over the counters, and she was doing heroin and got arrested, right? And was doing several years in prison over that. So there are good non-medication approaches to physical pain. There are some counseling interventions. Again, not a lot of people are expert in this. This is an area where, as a mental health professional, I think folks should be better trained. But, you know, especially for folks with addiction, having some of these behavioral ways to address pain is important. So I think, oh, look, that's my last slide. So we're happy to answer questions. Like I said, I just want to reiterate, we were thinking about everything from 911 calls, you know, through custody. We're thinking about the whole county. And the most important thing, I think, is to the extent that behavioral health services and crisis services in particular are strong in your community, you'll involve a lot of unnecessary burden on your police, on your jails, on your judges, and a lot of unnecessary suffering, and sort of life tragedy, you know, for those with mental illness in your communities. So I don't know, Faye, if you want to add to that before we take questions. Do you have parting thoughts before we take questions?
Yeah, I wanted to add to it because, still within the criminal legal system, there is the question of whether people should be on medications. And there are lots of instances where when people are in jail or on probation and parole, they are not allowed to take their medications. And so sorry, I really feel that, given the strength of the evidence about how useful medications are, that's something we should really rethink in the criminal legal system. So I'm really raising that here because, I'm hoping that the people who are participating in this webinar will go back and rethink that. And that requires, dealing with the attitudes of judges and prosecutors who often think that you're giving people medications for things that they should know how to control themselves. But, that's not necessarily the case for someone who has a brain disorder or someone who has an ailment. So so I want to raise that because it is a question about the policies that we have. We do have a couple questions in the chat box, which I can read, Jennifer, some you.
And let me add to your comment. Yeah, you know, if a provider suggested that someone with mania or psychosis can't take medications, like that's almost malpractice. And some of these things, again, I'm not trying to say that everyone is sort of, that there aren't, you know, but for people who have mental health conditions, it's, like I said, especially mania, some of those behaviors are not controllable because of the disorder, and they really have to be on medications, and to not allow that is just, I mean, you're just keeping the person sick. So
Yeah. And part of it is the criminal justice legal system, is not the medical system. And so, there isn't the recognition of how medications can really help, even with talk therapy, right? Part of the medications is they calm the brain down so you don't have all these competing sort of issues. And so people can really focus in on what the talk therapy is about. But it is an issue that has to do with implementation, and these attitudes get in the way. All right, so one of the first questions, Jennifer, and I don't know the answer to this, is whether or not you're aware of any evidence-based practices for treatment services for people with IDD or DD in the criminal justice system, legal system?
Yeah, that's a great question. As a matter of fact, I actually had that thought in the middle. So I would say, and they're so often comorbid, right? When I got to the county where I live now and I walked into the jail social worker and said, "Hey, I'm here to help," bless her heart, the first thing she did is start to cry. And then the thing she wanted help with when we offered to, have some medical student volunteers is just someone to sit in color with some of their people because they didn't understand what was going on, right? So definitely developmental disabilities. It's not an area in which I'm expert. I would say that I would say that all of these mental health interventions would also apply if the person has mental health disorders. I would say that a lot of the things, like the general practices that they brought up around supportive housing, supportive employment, services in the community, linkage to care would apply there. But you're right, it's a super vulnerable population who often has all of these things plus a developmental disability. But I guess my summary is everything we said would apply, and they may also need additional things.
Yeah, and I would say, that we in, this area of developmental disabilities is really under researched, particularly for people in the criminal legal systems. And so, we don't really know, other than, there are estimates that people in prisons, about 25 to 30% have some sort of development disabilities. And, but we haven't done a good job of exploring it. So I'm really sorry, whoever asked the question. I don't think we can recommend anything.
But and then let me add one other thing. Another thing is head injuries.
Yes.
There's a lot of head injuries, right? Which again can